The esophagus is roughly 25 centimeters in length. There's a laryngeal part to the pharynx, and then it descends down, pierces the diaphragm, thoracic vertebra level T10, and it has two main sphincters to it. The upper esophageal sphincter, which is a skeletal muscle, but is not under voluntary control. It's a reflex that's involved in swallowing. And then the lower esophageal sphincter, which is smooth muscle, which is completely not under any conscious control. There's three main areas where the esophagus will have strictures to it, and those are the at the pharynx, just behind the cricoid cartilage, and then descending down just by the aortic arch, which is roughly sort of 25 centimeters from the incisors, and then finally where it pierces the diaphragm. So there's three places where, if the esophagus is going to stricture, that's where it will. The histopathology of the esophagus, if you to look at the upper third, it would be striated muscle, and then it's divided into a middle third, which is both striated muscle and smooth muscle, and then the distal or lower third, which is only smooth muscle. So the cells involved with the esophagus are the non-keratinized stratified squamous epithelium, and this is important when we think about conditions affecting the esophagus. So gastroesophageal reflux disease is when you have a high volume of acid at the lower end of the esophagus, and the esophagus doesn't tolerate acid very well, as it doesn't have the mucosal type cells which secrete bicarbonate to buffer acids, and it's really due to abnormal relaxation of the lower esophageal sphincter, or abnormality in the angle of His. And the angle of His is the acute angle in which the esophagus pierces the diaphragm and enters the stomach, and it's this angle and with the musculature of the diaphragm which makes it difficult for gastric contents to come up the stomach. But if you have something such as a sliding hernia, hiatus hernia, then the sphincter will have slid up the esophagus or the diaphragm relative to the diaphragm, and that means that you lose this angle of His. Risk factors for esophageal reflux disease is mainly obesity, smoking, alcohol, and taking large fatty meals which take a long time to digest. And the treatment is risk factor modification, lifestyle modification, and first line would be proton pump inhibitors such as omeprazole and lansoprazole, or histamine blockers, H2 blockers such as ranitidine or cimetidine. So untreated gastroesophageal reflux disease will go on to Barrett's esophagus in roughly 10 to 20% of people, and this is when, instead of having the stratified squamous, it will then turn to glandular metaplasia. Metaplasia means a change in one cell lineage to another with abnormal stimulus, and that means that the stratified squamous turns to columnar epithelium. And usually there is a squamo-columnar junction, and this is where the histopathology changes from being the histology changes from being the esophagus to the stomach, and this is known as the Z line. But in chronic gastroesophageal reflux disease, because of this abnormal acid process, the Z line moves more proximal, so that you get more and more columnar epithelial higher up the esophagus. And this is a problem because whenever you have an abnormal stimulus, then you're at risk of developing an adenocarcinoma of the lower end of the esophagus. And that's what Barrett's esophagus is. And once it's a pre-malignant state, that can become an adenocarcinoma. An adenocarcinoma of the esophagus has got a very poor 1-year survival. So the treatment is to treat the underlying cause, which is the reflux, and then some people would advocate endoscopy, yearly surveillance to look at the level of dysplasia. And certainly if you have high-grade, very dysplastic changes, then yearly review would be recommended, whereas if you have a low-grade with low levels of dysplasia, then they would say you might be able to wait every 3 years would be the recommendation. The big thing that you want to avoid is developing esophageal cancer, and it comes in two types: a squamous cell type, which is of the upper third, which is more like a head and neck cancer, and this is the most common outside of the United States, and the Western world, and it's mainly due to smoking and alcohol. It's more thought of as being a head and neck type pathology as opposed to an esophageal one. It's the upper third of the esophagus. The adenocarcinoma is linked to Barrett's esophagus, and that's the lower third of the esophagus. And this is most commonly seen in the US, and that's where Barrett's esophagus is the main risk factor for this. The reason you don't see too much esophageal cancer has got such poor prognosis, and 80% mortality in the first year. And this is due to the fact that the way the esophagus doesn't have a serosal layer, which means that any disseminated disease will spread directly through the mediastinum very quickly.